So thank you so much for joining us for today's presentation. For those of you whom I have not met, my name is Rebecca Bedeau. I'm the Director for Strategic Communications at the Betty Irene Moore School of Nursing at UC Davis. We are glad that you agreed. Yeah, the title, it's a little tough, but yeah, we are all getting older, but it's not all bad news. In fact, Americans are living longer. The most recent report from the U.S. Centers for Disease Control says U.S. life expectancy is 78.7 years. That's an increase of a month from past reports, but we know that does come with some challenges. The rapid increase in the older adult population places unprecedented demands on our healthcare system and aging-related services. By 2030, the number of U.S. adults age 65 or older will more than double to 71 million people. Thankfully, UC Davis Health is ready to help older adults achieve their health and wellness goals thanks to the Healthy Aging Initiative. The vision is to create the healthiest and highest functioning older adult population in Northern California with care, research, and innovation. And here to share that vision and map out what it means for you are two experts in aging, one from the nursing perspective and the other a geriatrician. Dr. Deb Bakurjian is the Associate Dean for Practice and a clinical professor at the Betty Irene Moore School of Nursing. She leads the school's clinical enterprise as well as interprofessional practice, clinical partnerships, and strategies for the school's contribution to the Healthy Aging Clinic, which you will be hearing more about today. Her research aims to improve the quality of care for aging populations, really focusing on patient safety and quality improvement practices in long-term care, as well as interprofessional education and collaborative practice in primary care. Dr. Rebecca Boxer is the chief of the new Division of Geriatrics, Hospice and Palliative Medicine for the UC Davis School of Medicine. As a geriatrician, she cares for older adults with multiple chronic conditions, functional decline, dementia, and frailty. Her broad research interests include heart failure disease management, nursing home care, polypharmacy, and the social determinants of health. So now that the experts are in the room and a host of you have joined this noon hour, I will turn it over to both of them to share their latest work and how our entire region can benefit from it.
Thank you, Rebecca. Good afternoon, everyone. My name is Deb Bakurjian, and as mentioned, I'm the Associate Dean for Practice and a clinical professor at the Betty Irene Moore School of Nursing here at UC Davis. Dr. Boxer and I welcome you and thank you for being here today. I'm going to start us off with the first few slides, and then Dr. Boxer will take over. Next slide, please. Here is the agenda for today. We're going to describe the UC Davis Healthy Aging Initiative, along with our new Division of Geriatrics, which Dr. Boxer will speak more about. And along the way, we'll share what the initiative is doing related to education, research, clinical care, and a few accomplishments and future steps. Next slide. As Rebecca Badeau mentioned earlier, America is aging. We all know this. We've seen lots of information about this, but it's in fact aging at a pace that's surprising to many. One of the things that really is going to change over the next few years is that by the year 2035, can we go back to the prior slide, please? By the year 2035, the growth of adults over the age of 65 will outnumber the growth of children in the United States. And by 2060, older adults will be 23.5% of the population, while children will be less than 20%. This is for the first time, so this is an unprecedented change in our growth pattern. Next slide, please. Here in California, we have the largest number of older adults in the United States. The map on the left shows the concentration of adults over the age of 60 and older by county. The counties with the orange and red have the most growth, with the red having over 200% growth in those over the age of 60. Even more dramatically is the map on the right that shows the county breakdown for those over the age of 85. Here, the red is over 400% of growth, the orange 300% of growth, and the yellow 200% of growth. This is the fastest growing segment of society here in the US. And you can see right around Sacramento, which is right in the upper middle of the state, the upper third of the state, we are surrounded with red, orange, and yellow states. So a lot of concentrated older adults in this area. Next slide, please. So given that significant growth, that's certainly part of the impetus for the Healthy Aging Initiative. Next slide. As mentioned earlier, our vision is for older adults in the UC Davis Health region to be the healthiest and highest functioning older adult population, based on the care provided along the way with the research and innovation here at UC Davis. We have promoted an integrated approach to care across the lifespan and all care settings. This initiative represents a cultural shift in how UC Davis Health serves older adults and their caregivers using an age-friendly approach, which we'll talk about more later. Ultimately, our goal is world-class health care for older adults. Next slide. I mentioned the integrated approach across the health system and all settings of care, and this slide shows why this is important. When we examined our own health system, we could see there was some fragmentation in care between the ED, inpatient setting, outpatient environments, and this was particularly evident in thinking about other community clinics and other community settings, including nursing homes and other types of living arrangements. We knew that this was a problem and we were going to need to address that. So that is part of what we have been working on. We know that to provide optimal care, we need to address transitions across all settings, which are significant places where medical errors, nursing errors can occur. So it's a very important aspect of what we've been trying to do with the Healthy Aging Initiative. Next slide, please. So that brings us to our Healthy Aging Initiative. We have 5 pillars that segment our work, but each works in conjunction with each other. They are, first, to ensure UC Davis Health serves older adults in an age-friendly way across the entire enterprise. Second, to deliver age-friendly, person-centered care to optimize quality of life, function, and autonomy. And I want to concentrate, or I want to focus a little bit on this person-centered part of it. Each individual is different and unique. And what we want to try to do is to address care in collaboration with each person and their family members so that we can individualize the care. Conduct cutting-edge research across collaborative disciplines is number 3. Number 4, support family caregivers and develop tools for independent living. And the last one is to prepare the next generation of clinicians through degree programs and fellowships. I'm now going to turn this over to Dr. Boxer to talk about geriatric medicine at UC Davis, and she will explain age-friendly and address several important issues related to healthy aging and how we educate our learners. Dr. Boxer.
Thanks, Dr. Bakurjian. It's great to be here. We'll move on to the next slide. I just want to take a moment to talk about the building of the UC Davis Division of Geriatric Medicine. Now, this also encompasses hospice and palliative medicine, but for this purpose, I'm going to just focus on geriatric medicine. The division is now a year old. We're the new home for faculty in geriatric medicine, for education initiatives. Having a division advances our ability to partner for research and develop research infrastructure, primarily in clinical research. We also are working hard to expand our clinical services. This includes recruitment of physicians and nurse practitioners to care for older adults in the region. This is going to be an important part of our initiatives to improve outcomes for older adults. Expand our team care in multiple settings. That includes a multidisciplinary team, as I mentioned, NP and MD, but also pharmacists, physical therapists, social workers, etc. We also are advancing our digital health partnerships for access to research, testing, and promotion of innovation, which I'll talk about in a few minutes, and support and grow partnerships between disciplines and schools. A lot of our focus has been growing our partnership between the School of Medicine and the School of Nursing around older adult health and care. Next slide, please. So let me talk a little bit specifically about education. Next slide. So we have structured our education according to the IHI age-friendly health systems, which is an approach to older adult care that has 4 main tenets. And this is the framework that they proposed where we should focus ourselves for older adult care. There is a 5th one that I'll mention also, but first I'll go through these 4. So the first is mobility. So ensuring older adults move safely every day, reducing falls. Second is mentation, preventing, identifying, treating, and managing such things as cognitive decline, dementia, depression, and delirium, which is common in the hospital setting. The third M, medication, age-friendly medication, avoiding medications that can do harm to older adults, and avoiding polypharmacy. And lastly, what matters most, aligning our care for each older adult with what matters to them as they age and have to manage their chronic conditions and end-of-life care. The 5th M, which I also will include, is multi-complexity. That's having multiple chronic conditions that we also focus on. So this is guiding our educational initiatives. Next slide, please. So let me take a minute to talk about the Mini Medical School, which is, hopefully some of you have heard of it, our community program. The program concluded its 22nd season, or is close to concluding it. The participants are mostly participating online, although we do have some in-person participation, and the participants are primarily from the greater Sacramento area. The lectures include traditional disease and prevention, current health issues, mental health, lifestyle change, and caregiving, to name a few. And we will reopen registration for our 2025 season in November. I thought I would share with you some highlights from the Mini Medical School from this year. So next slide. And we're going to go along to the 4 M's, which I introduced to you previously. And the first I'm going to talk about is mentation. And I think that one of the key take-home messages that we delivered in the Mini Medical School, but also in our patient care and our education of trainees, is what is good for the heart is good for the brain. So all those things that we think about in terms of heart health, a healthy diet, avoiding sugars and excess salt, increasing physical activity, controlling blood pressure and weight, controlling cholesterol, getting quality sleep, and avoiding nicotine and smoking, all good for the heart. We now are very clear that it's good for the brain, and our goal is to reduce the advancement of cognitive decline and dementia. The blood vessels that get impacted by all these things that are in the heart also impact the blood vessels all over the body, including the brain. So I think this is to live by these recommendations for healthy heart care and healthy brain care. Next slide. Mobility. So our second M that we're going to talk about, that we gave a lot of information during the Mini Medical School, was mobility. I wanted to share with you how important mobility is in terms of its relationship with survival in older adults. It also is very strongly associated with disability. And you can see here, these 2 graphs are showing gait speed by age. The first graph is with men and the second graph, women. along the vertical axis, you see median survival, and then across the horizontal axis is age from 65 to 95. And you can see here that survival is higher at all age groups with a faster gait speed. And so being able to maintain gait, walking, and physical function is indicative of how long people will survive, and also how long they will be disability free. Next slide, please. And I just want to emphasize that mobility is about being mobile from wherever you are. So avoiding sedentary behavior might be the simplest approach to mobility versus all the way up to vigorous physical exercise. It is important that people get up and move. And so at any age group, we strongly encourage and devise plans with our patients to figure out where they are and how they can increase their mobility. Next slide, please. The third M, medications. Medications are a huge cost for many older adults. Many medications impact brain function and cognition and can increase the risk of falls. We have an inappropriate medication list for older adults called the Beers list. It's freely available online. Although we do use some of the medications when we have to on this Beers list, it does identify those medications that can be the most problematic for older adults. A few of them I've mentioned here, particularly sleep aids, over-the-counter sleep aids, such as diphenhydramine, which is in a lot of the medications over-the-counter that say PM on them, can impact cognition and increase risk of falls. And I'll also mention a drug that's quite popular called Ambien that increases sleep or helps people to sleep, can also have a major impact on brain function. Anti-anxiety medications, pain medications, and muscle relaxants are all commonly known to increase the risk of falls and reduce cognitive function. Next slide, please. And then the fourth M I'll talk about is what matters. So aligning care with individual healthcare goals. And I think the things that we talked about in the mini medical school and to think about is everyone has their own individual story. What is important to you right now in terms of your health and condition? What matters with the change in condition, with the development of acute or chronic illness? Being able to communicate your goals to those around you, your physician, your family, and making sure that you've chosen a healthcare proxy, someone to make decisions if you are unable. And there's a wonderful website called The Conversation Project, which has a number of free guides, which leads a person through ways of identifying or ways of strategizing how to make those decisions and how to communicate with them. Next slide, please. So I'm going to turn, so those are our 4M highlights from the mini medical school. And now I just want to mention additional educational programs that we've been working on in the last year since we started the Division of Geriatrics, Hospice and Palliative Care. We're working to expand training for students and trainees in order to increase the literacy of older adult care for everyone coming through our system for training. We've launched a new medical student rotation, which is the first rotation we've put together. There's going to be more, which exposes medical students to ambulatory geriatrics, inpatient geriatric psychiatry, inpatient palliative care, and neuropsychology, which specifically focuses on cognitive decline and dementia. We have internal medicine and family medicine residents rotating through our fairly new healthy aging clinic so they can get hands-on exposure to managing outpatient older adult care. We have a geriatric emergency medicine fellowship, which specifically focuses on emergency medicine and older adult care, where our geriatric fellows also will rotate. And our geriatric medicine fellowship, which started last year, we're graduating our first 2 fellows in 2024. So in just a few months, and we have 2 new fellows starting. We're very excited that this fellowship is moving forward, and is being sought after by trainees. We have advanced nurse practice residents who are coming into the Healthy Aging Clinic for a year-long experience with the Healthy Aging Clinic, where they can see older adults in ambulatory practice and can have experiences with the nurse-led mobile clinic. The School of Nursing has standalone geriatric courses in all their programs. There's RN, MP, and PA student rotations in geriatrics and geriatric psychiatry. We've just brought on a new geriatric psychiatrist to add to the team. And so we expect there'll be further expansion. And we have pharmacy residents coming from pharmacy programs who are rotating through the Healthy Aging Clinic and assisting us with polypharmacy and deprescribing. Okay, next slide. Okay, so research, I'm going to talk about briefly. Next slide, please. So we have, with the new division, have been able to augment and start planning for further research collaborations in aging, adding to the already great research going on in the School of Nursing. And so some of these include partnering with the School of Nursing Family Caregiving Institute, which is dedicated to the well-being of caregivers. You can see here that the Family Caregiving Institute has a number of collaborations, including with AARP. They're collaborating with the University of Utah, so outside the UC Davis system for caregiver nursing education. Graduate academic certificate in caregiving is available. And then additional research in advanced illness care, and you can see program policy evaluation of caregiver resources and other programs, hospital to home transitions, and patient safety and quality of care for older adults and caregivers. Additionally, we've started to collaborate across the causeway. So we now have a UC Davis researcher who's coming to the Healthy Aging Clinic to collect data around gait and mobility. This researcher is coming in once a week to work with the patients we're seeing in clinic and to collect some data and develop a gait assessment tool, which hopefully we'll see some results from that in another year. We expect we'll have more research coming through the Healthy Aging Clinic as well. The Alzheimer's Disease Research Center is flourishing in both basic and clinical research. And a lot of patients in HAC come through and opt to go to the Alzheimer's Disease Research Center for further evaluation and contribution. And then lastly, Healthy Aging in a Digital World, which is bringing creative solutions through technology to enhance older adults' daily life. We have some really cool things going on from that group in innovation and technology. Next slide, please. Here's the vision for digital health and telehealth for older adults and the caregivers at UC Davis. This is part of Healthy Aging in a Digital World, HADWA, as we call it. And you can see here, our programs are focused on the body, including sensors, measuring vital signs, sleep, mood, medication adherence, etc. We have in-home devices that we're studying, how to make the home more safe and interactive with an older adult so they can live longer within their home independently. And then community social communication, reducing social isolation and loneliness. And all of these initiatives in some way could interact with primary care team, and the primary care teams on their own are also advancing telehealth and e-consults and bringing more specialty to older adults within their home, so they don't always have to go to a doctor's appointment. Next slide, please. Okay, and with that, I'm going to hand it back to Dr. Bakerjian.
Thank you, Rebecca. I'm going to focus on the last issues, and that is clinical care. Next slide, please. This is our Healthy Aging Clinic. You can see at the very top left picture our ribbon cutting that happened during COVID, which is why everybody has masks on. Below that is our waiting area, and to the right is one of our nurse practitioners working with a patient on mobility. The clinic has many types of providers who take a team-based collaborative approach to care. In addition to traditional geriatric care, we also provide caregiver consultations and services, as well as a strong dementia care program. The clinic has nurse practitioners, physician assistant, medical, and we hope in the future RN students, led by our geriatricians and other clinic staff. And Dr. Boxer described many of the types of providers that are there in the clinic, not only providing clinical care, but also working on research. Pretty exciting stuff going on over there. Next slide, please. We've had a number of accomplishments in the hospital, so I'm going to turn to the inpatient world. Since the start of the initiative, you now understand the age-friendly part of it. That's the 4 M's or 5 M's that Dr. Boxer described. But the other program is called Niche, which I'm going to explain in just a moment. This slide, though, is about opportunities for improvement, recognizing common problems that older adults experience, like delirium, falls, and longer lengths of stay, and determining ways to prevent those or at least decrease the occurrence in our hospital settings. We are also focused specifically on improving communication with patients, ensuring that we align care with the patient's goals, and that's what matters and person-centered approach that we're taking. It also improving sleep, nutrition, and mobility. Again, we can't overemphasize the issue of mobility. Next slide. So a little bit more about the Niche program. This is Nurses Improving Care for Health System Elders. As everybody realizes that our physicians that come into the hospital examine and treat the patients on a regular basis, but the nurses are there for several hours with the patients after the physicians leave or in between the physician visits. So the Niche program is the vision to create an age-friendly health system that provides innovative, evidence-based, and compassionate quality of care to older adults. In December of 2020, UC Davis Health was recognized as an early member level of Niche. And then since that time, we piloted the program on one unit, Davis 14, identified gaps in care, developed action plans for improvement, conducted training, and importantly, identified and trained staff experts known as geriatric resource nurses. And then we were awarded the Niche designation in early 2023. Next slide. This just shows you the number of steps that went into this process, and you can see that it took several months to get through the Niche designation. So it is quite a big deal to be Niche recognized, to have that designation in your hospital. Next slide, please. And then subsequently, we have trained many more of what we call the geriatric resource nurses. This is the nursing model that you see here. The model is focused on nursing providing evidence-based care, as I mentioned, person-centered care, but also working within the interdisciplinary team of physicians, pharmacists, therapists, social workers, and others. We are collecting data and measuring outcomes and beginning to see the improvement, things such as fewer falls and reduced length of stay for our older adults who are in the hospital. And I would just say the other thing is that we started with piloting it on Davis 14, one unit. It is now spread across many, many more units. We had initially our first cohort of 10 registered nurses trained. We now have over 75 registered nurses trained throughout the hospital. So a really great, successful program that has been conducted over the last few years and now will be maintained. Next slide, please. And I would just say, not to be outdone, our UC Davis Health Emergency Department is now recognized as an accredited Level 1 geriatric ED, thanks to the efforts of Dr. Katrin Tyler and her team. This is also quite an accomplishment, which meant a lot of studying, a lot of changing of policies and procedures, a lot of education for the staff, and is truly an accomplishment we're very proud of. Next slide. So this is just a summary of what we've kind of accomplished over the past few years of the Healthy Aging Initiative. I'm not going to read all of them, as we've mentioned most of them, but a few I would add is what we have developed from that we have developed team-based care simulations to train providers in geriatrics in a simulated environment. The School of Nursing and the School of Medicine have wonderful simulation centers, and we work closely together in sharing all of the resources that we have. Dr. Boxer mentioned our nurse practitioner residency and fellowship program. I just want to mention that we have graduated 6 adult Gero nurse practitioners from the 12-month transition to practice program, and hope to add several more in the next few years. And lastly, the School of Nursing and School of Medicine work together to submit our own Geriatric Workforce Enhancement Program grant proposal, and we certainly hope to be funded. We're really excited and proud of the submission that we sent in. This would provide additional training for medical and nursing students and residents, and funds to enhance training in the community and across settings of care, including organizations such as nursing homes. Next slide, please. So in the future, as mentioned, we're in the process of hiring additional staff, and we're certainly working hard on further integration of services and integrating geriatric standards of care across our entire system, including both of our schools. We hope to increase in community outreach, implement a reimagined mobility program that Dr. Boxer mentioned is going on in the Healthy Aging Clinic now, and also to grow collaborative research. Next slide. So thank you very much. We appreciate your attention, and we'll now turn it back to Rebecca Badeau for questions.
Thank you very much, Drs. Bakerjian and Boxer. Lots of good information to synergize. One of the things I want to ask you, and please put your questions in the Q&A so that we can get to them. We've got some coming in right now. But, you know, we love statistics, right? We love data as we look at life expectancy and how many people are going to be a certain age by a certain year. But Dr. Boxer, let me pitch this one to you. Some of those life expectancies, you know, we gave what was the one we gave? It was 78.7 years. The CDC said that. But if you go a little deeper, Hispanic life expectancy is a year shorter than that. Black Americans, only 71 years is the average life expectancy. Then you go in even to indigenous populations, it gets as low as 52 for men living on reservations. Asian American is 84, so it's on the other swing of that. How are we working in these disparities that we're seeing and the different numbers in the research that we have, in the way we're approaching clinical care? Because obviously it's not that one size fits all approach.
Yeah, that's a really good question, and it's a very complicated issue in terms of all the factors that impact people from different backgrounds. And so it's probably out of the scope of this talk in terms of from a clinical standpoint, but I can address the research issues, at least what we're doing. There's a lot of interest in this area from large research bodies within the United States of how to make research access more fair, and that people of all backgrounds get access to innovative new therapies. For one, there's also a lot of interest in improving study designs and how studies are conducted to make them more fair and to give people more access, providing people, let's say in lower socioeconomic groups, provide them with the support they need to actually participate, to take language out that can be misconstrued or cause bias, or make people unwilling to participate because of the way things are laid out in consent forms and study protocols. There's language that exists in some of these trials that is not appropriate for all populations. So really taking a good look at the way that we're mapping out how these studies are perceived. So there's a lot that's being done, I think, particularly for UC Davis, in terms of what I feel is also important is really understanding the communities and creating partnerships with the communities, as the School of Nursing is doing, and hopefully our division will do as well, to hear what people want and what their biggest concerns and needs are, and designing studies that are appropriate and address those needs.
And I think also weighing in the fact that there are populations who, rightfully so, historically have a mistrust of the health system. So getting them into clinical trials so that we can have that diversity of a pool to look at these new approaches and these new medical interventions is important as well, correct?
It is, and I think it's really about rebuilding that trust, and on the research side, us doing better in terms of communication, and really recognizing that this adds value for people. Like when people need research or they need advanced therapies, that they feel comfortable seeing it as part of their options for their medical care.
Rebecca, I would just add that I think we do one other thing really well here at UC Davis, and that is that for our students, our learners, we put a lot of emphasis on recognizing the disparities. We teach a cultural humility approach to how we work with communities, how we work with our patients, recognizing that they often know more about their culture, about what's good for them than we do in some ways. And so having that approach and making sure that our learners understand that they understand the disparities and the historical challenges that we've had is, I think, really a big contributor as well to what we're doing.
Yeah, absolutely.
I'm glad you added that, because we could see from your presentation that is the strength of an academic health system. You have the clinical care, you have the research, and then you've got that education, right, for the future providers who are learning and modeling this level of care. So I'm glad that you kind of tied that together for us. A very popular question we get, Dr. Boxer, is how can one access the Healthy Aging Clinic? Can you walk us through that process?
That it's it's a good question. I mean, I think that it somewhat depends. So for those who have primary care within UC Davis, it's a referral to the Healthy Aging Clinic through your doctor, because we are right now a consultation service providing geriatric consultation, where you continue to work with your primary care doctor, but we provide sort of that geriatric lens of how we would recommend the trajectory of your care and changes that to optimize care considering an older age group. We will take outside UC Davis also, but that still has to come from or as a referral. Right now, the program at the Healthy Aging Clinic is not promoting a primary care program. I will tell you, I would really like to see that happen in the future. I think that having geriatric primary care available to the community is one of our goals in the future.
Excellent. And I will, we're going to put in the chat the website for the Healthy Aging Initiative, which does have an information or contact number for the Healthy Aging Clinic. It's always good to ask, but that referral piece is definitely important within UC Davis Health and without or outside of UC Davis, if that's your provider. You brought up the Family Caregiving Institute, obviously a large research arm within the School of Nursing. And they've been working a lot with the initiative. But Dr. Perkursian, can you talk a little bit about maybe what other programs we envision outreach, particularly to caregivers within this healthy aging work?
Yes, certainly. So we have just placed our geriatric clinical nurse specialist within the Healthy Aging Clinic. And she is going to continue and expand upon the caregiving visits that are being done. She's also starting to work on a program of research in the area of caregiving. We have several faculty members, nursing faculty members that are working specifically on research around older adults with either a chronic illness, particularly those with dementia, and their caregivers, and in different aspects of some of the challenges that they come across, whether there are best practices in terms of having better outcomes and those kinds of things that are going on. And I do want to say, even though the Family Caregiving Institute is situated within the School of Nursing, we are interprofessional. We have physicians who participate fully in the programs there. We also work with outside the community, we're doing program analysis. We have a number of videos that we've recorded for caregivers that are freely available on our website for caregivers to help them to better understand how to take care of their loved ones.
And that's a huge population. 53 million Americans now provide care or considered unpaid caregivers in some scope. So obviously hungry for that information. One of the questions that we had submitted in advance, very interesting. So does UC Davis offer any home-based care programs for providers, such as home-based primary care or hospital follow-up visits, to improve access to care for those homebound older adults? I'll pitch that to either one of you who wants to take it.
Well, I can start a little bit of it. UC Davis does have what's called hospital at home, where a patient has been in the hospital, is relatively stable medically, but needs to have ongoing what is called recognized as hospital level care. And so there is a program that has been going on for the last couple of years around that. There's some other home-based care. There's a couple of our physicians who do home visits. So that's another program. I don't know whether I don't think we have anything around independence at home or any of the nursing home level care programs. Dr. Boxer, do you know whether or not we have those?
No.
Yeah, I don't think so, but I do know that we have the hospital at home. And I think more and more we, as a health system, recognize that if we can keep patients out of the hospital, once they're acutely medically stable, right, the acute piece is over with, we either can send them home in their home environment or into assisted living or wherever they live, that we can provide a lot of services that are better for them in that home environment.
Right. And you bring up that aging in place. I mean, people want to live independently as long as possible. That's really where the healthy aging in a digital world comes in, because researchers there are really looking at the technology that can be placed in homes so that we can get real time, up to the minute feedback of how those older adults are doing. Did they get up in the morning? Did they take their medicine this morning? What is their gait? Is it slower? Is it more, are they stumbling more? So that's kind of where that research angle comes in too, so that older adults can live the way they want to, that what matters piece, and live independently and age in place as long as they can. Okay, so
Can I just
yes,
comment on
please.
the in-home care, because it's a really important question, and I think that, you know, we don't have everything in place. I mean, Deb and I have dreamed up all kinds of things that we hope and wish for in the future, and some of it has to do with just having enough trained, really specialized staff who both from both schools that can operationalize a home care program, and so that's important. We do have home-based palliative care, which is really focused on patients who have higher palliative care needs, may or may not be close to the end of life. It's not hospice, it's really focused on symptom control in the home. So that program is up and running. We also do have a one-time home visit that's outside anything to do with insurance, but we will evaluate safety in the home for an older adult. And so that's also available. That's through our home care program. So we feel a slow march towards improving in this area. And it's just gonna take some time, but I do think it's very much needed to advance in this area. Thank you.
So you mentioned the mobility, that chart you showed with aging and mobility and how well we age. That was kind of an eye opener for me. What are some other ways we can prevent aging? Is it diet? Is it socializing? Is it just walking, you know, to the refrigerator? What are some real practical tips that we can do to maybe not prevent aging, but stave off some of those negative effects that growing older can have?
So I will really jump on this mobility bandwagon. Because physical function, having good use of your lower extremities, being able to do for yourself all the things you need to do to care for yourself, when you have some kind of injury or surgery, that you work hard to regain your physical function and mobility, will really serve you well as you age and you get into the oldest old age groups. One of the biggest things that slows people down and that obviously impacts their outcome is their loss of function. So yes, I'm very much focused on exercise, whatever that looks like for wherever a person is. Social isolation and loneliness are also of major consequence, and being able to adjust to the things that happen to us as we age in our lives, losses and all sorts of different changes that occur, including things like retiring, are to be able to adjust that and sort of redefine social interactions, because it's very important to maintain cognition. And so I probably could talk, you know, for an hour about all the things, but I'll highlight those two and I'll let Deb add in a few things.
Yeah, I totally agree with the two that you've talked about. And I think, you know, staying active mentally is another piece of that. So whether that is part of that is the socialization of having relationships and being able to, you know, talk with people, but it may also be reading. It may also be learning a new craft, whether it's art. So engaging the mind and purposeful activity, I think, is another really important part of trying to make sure that you maintain overall function and enjoyment in life.
That's that mentation piece, because right, we want to stay as sharp. But what about when those things, you know, the forgetfulness, the finding your car keys in the refrigerator? Not that I'm judging, because it has happened. But when the forgetful things, are we looking at diet? Are we looking at engaging socially more? What are some of the things you know, that we can start addressing? Is it a conversation with our healthcare provider and not be in denial about maybe some things we're seeing, or if we're a caregiver to an older adult, what we're seeing in them?
My first response is yes. I think, and I think what you're asking, if you're starting to see that you're having some of these things, that leaving the car keys in the refrigerator, which is an interesting place to keep them, but you know, if you're seeing things, you're concerned, because there is some normal expectation that our minds are not going to be as sharp per se, or we might forget names, you know, that come to us later. They're definitely, I mean, just like the rest of our body, the brain has some wear and tear. If there's concern, though, seeing a physician is good, because there are a few things that we can look at and we can assess that can help us to manage things that are reversible. There are some illnesses or deficiencies that can result in cognitive issues that we would want to rule out. And that we could treat. And then kind of work from there. I definitely see people that have mild cognitive impairment that never advance to dementia. They just have to take a little extra care. They need to write things on calendars. They need to make sure they're socially interacting and they're getting their physical activity, and they're trying to make sure they control their blood pressure. Blood pressure is coming up over and over again, is a very important issue when it comes to brain health and keeping that blood pressure under control. So yeah, there are a lot of things that can be done on the medical side and also on everyday social side that can stave off worsening cognition, which is really what we have right now. We don't really have treatments, as you know, for full-blown dementia that are meaningful or without considerable risk at this point.
So that magic pill to cure Alzheimer's, we're not there yet.
No.
Yeah.
Sadly. But you know what, earlier you talked about the conversation project, and it is talking it through. Don't keep this within yourself. Don't keep this, you know, under wraps. Talk it through with your provider, with your family, with your friends, with a trusted individual. Yes, is that what I'm hearing?
Yes, absolutely. That conversation project website is really cool. Like, it's got so much great information on it. It's not the only place. It's just one that I like, but there's lots of places to potentially get that information and to help guide you with decision making.
And those resources are really important, because I think if you feel alone, or if you feel like you're the only one caregiving for someone, that feeling alone and not knowing where to go, there can never be too many resources. Is there anything y'all want to add before we wrap up? Okay. We want to thank you all so much for joining us today as we walk through the multi-complexity of the aging process. But obviously it's something that we should embrace and use all those resources that are available to us, as well as the wonderful care, research, and education being provided here at UC Davis Health. The impact of the Betty Irene Moore School of Nursing at UC Davis Health is really amplified by your philanthropic support. Whether your interest is in supporting patient care, research, or educating that next generation of scientists, physicians, nurses, and care providers, we are ready to assist you in finding the impact your gift can make to UC Davis, the world, and beyond. Please contact Carrie Cloud. Her information is here if you have any further questions about our conversation today, or you're interested in supporting UC Davis. Thank you again, Dr. Bakurjian and Dr. Boxer, for taking time out of your very busy schedules to join us and really share this valuable information and really show how UC Davis Health is believing in better healthcare for everyone at every age, and really leading the way in many of these areas and setting an example for our region. On behalf of UC Davis, we hope you stay well, stay connected, and we hope to see you next time. Take care.